Hello, and welcome to this episode of In Discussion With from Medical Update Online. Today I'm talking to Dr. Philip Chennell about hypodermic syringes and how the syringe material can affect the drug substance inside the syringe. Why don't you start by introducing yourself?
So I'm Philip Chennell. I'm a hospital pharmacist at the teaching hospital of Clermont-Ferrand, which is in France. And I'm in charge of the quality control and development laboratory in the hospital pharmacy, and also a member of the Material for Health research team at the Institut de Chimie de Clermont-Ferrand, which is the chemical institute for science in Clermont-Ferrand.
And can you give us a brief overview of your role, what your current job involves?
My hospital duties allow me to be in charge of the quality control department, in which I supervise the physical, chemical, and microbiological testings of the pharmaceutical preparations that our hospital pharmacy produces for our patients. And in my university research setting, I teach pharmaceutical science and actively investigate content container interactions.
You recently presented a short communication at the JAUPAC Congress in France, in which you described the use of two different types of syringe for bevacizumab solutions for intravitreal injection. And this is what I'd like to talk about today. But first, a bit of background. What is an intravitreal injection, and when might such a procedure be required?
An intravitreal injection is a medical procedure in which a medication is directly injected into the space in the back of the eye, and that space is called the vitreous cavity. And I suppose you could say it's filled with a jelly-like fluid called the vitreous humor gel. It can be used for the treatment of a certain amount of retinal pathologies or illnesses, like, for example, age-related macular degeneration, choroidal neurovascular membrane, or macular edema, or also for the treatment of endophthalmitis.
So, what's the problem here? Isn't it just a matter of drawing up the solution and injecting it? Or is there more to it than that?
Well, yes, there is actually a lot more to it. Firstly, it's a procedure which isn't completely devoid of risk because you have to inject a medication into the back of the eye. And the medication needs to be sterilely prepared and manipulated with care. But you've also got to realize that there can be interactions with the medication and the syringe which is used. And these interactions can cause a certain amount of compounds, in this case silicone oil, which can migrate from the syringes which are used. In this case, the silicone oil is used as a lubricant. And what happens is that this silicone oil can accumulate, especially if the patient has numerous injections. It can accumulate into the back of the eye, and it has been shown that it can cause reduced visual acuity, endophthalmitis, or, for example, a reversible rise of intraocular pressure. It's also been noted that certain patients have this impression that they have like floaters uh, impacting their vision to a certain extent. It's a medical procedure which can be risky because we are injecting a medication into the back of the eye, so it's not always that straightforward. But you've also got to take into account the fact that there are several types of medications which can be injected, and these medications all have more or less different physical chemical properties. And some of them can interact with the syringe, which is used in the medical procedure.
Of course, bevacizumab is a monoclonal antibody. Is there any problem with aggregation of the drug?
What's interesting here is that bevacizumab, which is an antivascular endothelial growth factor, normally used as a chemotherapy agent, For the treatment, for example, of age-related macular degeneration, can reduce the impact of the disease, really make it less pregnant. But unfortunately, it's also the actual composition of the drug, notably in this case the excipients, which have this tendency to extract the silicon oil from the syringe. And once the silicon oil is extracted, as we said, it can end up in the patient's eye, but it can also cause an aggregation of the antibody, which will interact on the water-oil interface of these little oil droplets, these little silicon oil droplets in the medication which is being injected.
Hmm. And is this a problem for the patient? I mean, can they see the particles?
The patients shouldn't be able to see the bevacizumab particles because they, thank goodness, are subvisible particles. But the problem we have here is that when this antibody, because bevacizumab is a monoclonal antibody, when it aggregates, which means that several of these molecules all come together at the surface of the silicon oil droplet, it can induce potentially modifications of its structure and therefore of its potency.
Now you've given us the background here, could you talk about your study? What did you do?
In our study, what we wanted to do was investigate this tendency of bevacizumab to interact with silicon oil droplets by comparing two types of syringes. Syringes which had the usual silicon oil used as a lubricant, and syringes which had a silicon oil which was cross-linked to the surface of the barrel of the syringe, meaning that it couldn't be extracted out of this barrel. So our main hypothesis was that these cross-linked silicon syringes would induce less aggregation, less modifications of the antibody, so that therefore it wouldn't impact its stability compared to normal silicon oil lubricated syringes.
Hmm, interesting. Could you say a little more about how you did this?
To investigate our objective, we filled a several amount of these syringes of each type and then stored them for up to 3 months in two different temperatures. The usual refrigerated storage conditions and so 5 degrees, and a heat stress condition at 35 degrees, which was what we call an accelerated study. And then at determined intervals of time, we extracted some of these syringes from their storage departments and subjected the content of the syringe to a several amount of physical chemical assays. Namely, we investigated the aggregation index of the solution. We performed size exclusion chromatography on them, did subvisible particle counting, dynamic light scattering, and also the classical visual examination of the content.
Hmm. So those techniques that you mentioned, is it fair to say that they are all techniques to estimate the numbers of particles and the sizes of particles formed?
Now, what these essays allowed us to understand, or to at least gain insight into, was indeed the number of particles, their size, but also how the antibody behaved. Did it fragment, or did it aggregate into high molecular weight species, which hadn't, for example, quite yet formed particles?
So what did you find?
The main result of our study was that the physical stability of bevacizumab solutions, that means how intact they stayed, shall we say. So this physical stability seemed to be superior with the cross-link silicon syringes compared to the classical normal silicon oil lubricated syringes. Indeed, we showed that there were less particles, that the bevacizumab was maintained its initial nature. It didn't fragment, didn't associate itself. And all those elements pointed towards the fact that um, these differences would be probably likely linked to the presence of the silicone oil because that was basically the main difference between these two syringes.
Hmm. And what were your conclusions?
Well, I think the main conclusion, what can all be drawn from this, from a pharmaceutical point of view, is that it shows yet again that choosing the right primary container for monoclonal antibodies, or in fact any medication, really remains primordial if you want to maximize patient therapeutic safety. That's really the main point.
Hmm. You've presented some interesting findings here, but wouldn't it be okay for the clinician just to draw up the injection immediately before administration? Then they wouldn't have to worry about stability or leaching or those kind of things.
That's true. You could, and it does happen, yet nevertheless, even a brief contact can be enough to start generating these interactions. We also showed that mechanical stress can impact how these silicon droplets are created. So even sometimes just manipulating the syringe, or sometimes, for example, knocking it a little bit, to remove air bubbles, could create enough energy, I should say, to release these silicon droplets and therefore start impacting the bevacizumab medication.
Hmm. So is there a benefit to providing ready prepared bevacizumab injection in this way?
Yes, definitely. You've got to realize that by preparing these syringes directly in a pharmaceutical compounding unit, it allows us to provide ready to use, ready to administer syringes for the ophthalmologist or the end user, which means that they save time, they don't have to perform the manipulation themselves. All they need to do is to just take the syringe, adjust the needle, inject.
Are cross-linked silicone oil syringes more expensive than the conventional polypropylene syringes?
These cross-link silicone syringes that we've studied are not currently available for hospital pharmacy use because the packaging in which they are commercialized by the manufacturer doesn't quite fit our needs. You see, these are products which are generally marketed for big pharma companies, and our use, which is, let's be honest, nowhere near the millions of units that these big pharma companies can be producing, means that we have to have devices which are packaged in a quantity which is sufficient and yet not too much for our use. We can't really purchase a big bag containing 1,200 syringes and expect to be able to do something with them when we see that in our clinical setting, we only use a couple of dozen every week. Okay, after a year, it does add up, but we don't need 1,200 in one big go. And how would we store them? How would we keep them sterile?
I see. And my last question, have your findings influenced practice?
Our findings were presented, as you mentioned, to the GERPAC conference in France last October. Since then, we've already been contacted by several of our hospital colleagues who are interested in our findings. So yes, let's say that at least we've got the stone rolling. And we are looking for alternative solutions because the syringes that we tested, as I just mentioned, aren't available. But we are trying to find perhaps different manufacturers which might be able to provide at least an intermediate solution, or something which is better than what we're doing at the moment.
Philip Chennell, thank you very much for talking to us about this little-known aspect of injection preparation. That really has been fascinating and thought-provoking. For more information about Philip Chennell's work, please visit the website using the link in the description, and be sure to subscribe for more news, videos, journals, and podcasts. For updates straight to your inbox, please follow the links below. And thanks for watching.